Okay, so welcome everyone to this webinar of the International Academy of Cytology. It's my pleasure to welcome Christina Zioga with us. Welcome, Christina. So Christina is a consultant cytopathologist at the Papanikolaou General Hospital in Thessaloniki in Greece. And she has a great experience in pathology because she started working as a laboratory technician, and when she gets a degree in medicine and is a cytopathologist now. He was responsible for the IT part of the Hellenic Society of Clinical Cytology, and she conceived and launched the teleconference series that were like our webinar educational conference online that had a great success. We know her because she was listed in several years in the journal The Pathologist as in the power list, and she is also active member of several non-profit organizations and an active member of International Academy of Cytology, where she also as a Twitter account, and for this reason I personally thank Christina to tweet all the nice activity done by the International Academy of Cytology. So before to give the scene to you, I was impressed by the fact that you are a certified lifeguard and you are also a passionate first aid instructor. And probably you take from this experience the objective of your talk. So I give you the word, and you can explain better why you choose this subject.
Thank you so much, Massimo, for this very kind introduction. So, good morning, America. Good afternoon, Europe and Africa. Good evening, Asia. Good night, Australia. Kalispera from Greece. Dear colleagues, members, fellows, and friends of the IAC, thank you so very much for being with us today. I'm very honored. It's always a great pleasure to do things for the IAC and with the IAC, because the Academy is our own society. Have you ever wished for being guided to a faster diagnosis with fewer mistakes? That's what Diagnostic Medicine algorithm is for. And I'm here to share with you a skill that can make you happy, because it can help guide your cytology diagnosis. The good thing about the algorithm is that it's actually what we all do every day, but in an easy to use ABCD ritual guideline, very easy to remember. What's even better, it's that it's generic and can be used not only in pathology, but in radiology and nuclear medicine as well. By far, the best thing about the algorithm is that it can lead us faster and safer towards the correct diagnosis. During this session of approximately 39 minutes, I will explain to you the ABCD algorithm. You will see how we in our laboratory have been using it in our everyday practice. I will also share the advantages and the challenges we faced during these years. In the end, I'm going to make you an offer you cannot refuse. So, now, I want you to, now that you're in front of your screens with your glass of wine, your a cup of coffee, or your cup of tea, I want you to get a pen and paper and to open the chat, because we are going to need it. Now that you got your pen and paper, jot down the questions that come to your mind when you have a cytology, when you have a slide to diagnose, when you have a case to diagnose. Let's say you have a pleural effusion. What are the questions that come to your mind? How do you proceed diagnosis? What is your logical thinking? What is your diagnostic approach? You have 2 minutes. Time, go. What is your logical thinking? What are the questions that pop up when you have a slide diagnosis? Time is up. So, did your answers include expressions like adequate, abnormal, benign, malignant type? Yes, yes, right, Vandana, and Lina, and Lucas. Ah, Luca, hello. And who of you have those points on your list? Please write yes in the chat. At least one of these points. Right, open the chat and write yes. If you have at least one of these points. Yes, Yorgo. Perfect, perfect. So our questions are like, do I have an adequate sample? Is it abnormal? Now look at what Woody Allen said in Deconstructive Harry, the movie. Yes. Is it beautiful? Is it malignant? What type? Have you ever participated in an IAC tutorial? If not, I highly recommend it. It's a must for your bucket list. You're going to have fun and you will learn so much within 3 days from the very best. The next one is planned to be in Sydney and another one in London. Is that right, Dr. Chandra and Ms. Austin? If you have participated in an IAC tutorial, you must have come across such a slide. Yes or yes? Do you recognize the author? Do you recognize the author? I see your Irene. Yes, of course. It's Dr. Syed Salih's slides. Now, look carefully how the Diagnostic Medicine ABCD algorithm matches this philosophy. Isn't it amazing? I told you, Diagnostic Medicine ABCD algorithm is what we do every day, but in an easy-to-use ABCD ritual. A is for history, B for adequacy, C for morphology, D for diagnosis, and E for report. This simplified mnemonic is a pathway to the procedure of interpreting pathology slides. You can use it as a memory aid to determine the order in which diagnosis should be approached.
Diagnostic Medicine
That's it, ABCDE. You can go now or stay if you want to feel more confident about making a diagnosis in the future.
algorithm is for. Diagnostic Medicine ABCDE algorithm will guide you when you have a radiology, pathology, or nuclear medicine image to evaluate and interpret. It all starts with a preliminary step correct. We have to make sure that the image is adequately labeled and prepared. A stands for available information. We establish the basis of our diagnosis by gathering all available information concerning the patient and, if possible, his full medical history. B, body. Once we come across the image, two fundamental questions should be answered. Which part of the body does the image concern, and where applicable, if the image is adequate? C, cancer. At this stage, we decide about the neoplastic or not character of the lesion. We consider morphology, and if needed, we perform ancillary techniques. D, diagnosis. We make our decision in our mind by either forming a differential diagnosis list or we reach a final diagnosis. E, exhibit. At this final stage, we exhibit our findings by writing a report. So follow the ABCDE steps and you'll end up with a faster diagnosis and less mistakes. For more information, follow this link or type Diagnostic Medicine ABCDE algorithm on Google or Public. Thanks for watching.
You will find the link to this video in the chat later. If you feel the urge to give it a thumbs up, please feel free. I'm not going to stop you. So let's get started with ABCD. Preliminary step correct. And A, refer to the pre-analytical phase of our diagnosis. We have three phases, the pre-analytical phase, analytical, and post-analytical. So in the pre-analytical phase, we have correct and A, available information. B, body. C, cancer, and D, diagnosis to the analytical part of it. And E, exhibit to the post-analytical phase. Everything starts with this preliminary step, correct, here. You can find these laminated diagrams in Twitter and in Facebook and in LinkedIn. Incorrect, we cross-check the number on the slide with that on the request form. They have to be the same. I have been working as technologist in histocytopathology laboratory for 5 years. I can reassure you that a pre-analytical error, like sweeping the order of a slide, or the request form, can happen no matter how careful, watchful, alert, attentive, or cautious we are about our job. In our laboratory, approximately twice per year and per colleague, correct steps saved us from making mistakes. In the correct step, we also make sure that our slide is adequately labeled and prepared, because sometimes those slides, they just refuse to be dyed and cover slipped correctly. Correct step is a safeguard. It protects our diagnosis for pre-analytical errors, like making a diagnosis for a wrong patient. Still in the pre-analytical phase, A, letter alpha, the first letter of Greek alphabet. I hope you don't have to learn all the letters with COVID variants. Any one of you know these guys? I can see your responses in the chat. Do you know these guys? They are super important for A. A stands for available information. Clinical history. What we know about the patient. Our ancestor, the father of medicine, Hippocrates, said, declare the past, diagnose the present, foretell the future. In this order. Can pathology diagnose the present? Yes, sure. Can we foretell the future? Somehow, yes. What we need to know is the past. That will make Hippocrates happy. William Osler, the father of William Osler, the father of modern medicine, said, listen to your patient, he's telling you the diagnosis. Parenthesis, a historical cookie. Dr. Osler was one of the 4 founding professors of Johns Hopkins Hospital. Is that right, Dr. Ali? In Baltimore. That's where the biggest cytology congress will take place this year in November, organized by both IAC and the brilliant and unique American Society of Cytopathology. How many members, do we have members from the IAC? Do we have members from the IAC? Right, yes, in the chat. Okay, let's hope we can all meet in person this time. I could speak for an eternity about the importance of full clinical history, but let's make a long story short. At step A, available information, we establish the basis of our diagnosis by gathering all available information and, if possible, the full medical history of the patient. It was early in the lab, in the morning, in the lab, and the smell of my herbal tea was all over the office, along with my mother's tasty Greek cookies, when suddenly my phone screams. It's Kondakiotis, the director of Pulmonary Clinic. I have sent you a bronchial brushing of my cousin named Papadopoulos. Greek names are easy to pronounce, right? Take good care of it. And before I even had time to ask questions, he had already hung up the phone. I took a look at the corresponding request form, only to see that it was blank. Have you ever received a blank request form only with the demographics of the patient required by the system? No history at all? I can see your virtual notes. Something had to change. So we wrote a formal letter to all directors, kindly asking both them and their personnel to always provide key points of medical history and most important radiological findings on the request form. Did this make any difference? Yes, it did. Do we still have a long way to go? Yes, we do. And that's it. A good clinical history establishes the basis of our diagnosis. Moving to the analytical part of our diagnosis, B, body. Now it's the time to turn on the microscope. Now it's the time to slide the slide on the microscopic stage. Once we come across the image, we want to answer 2 fundamental questions. It's essential to know what to expect from an anatomical point of view. Hence the question, which part of the body is being examined? Topography of the lesion. And 2, do we have an adequate sample? Are there any adequacy criteria for this sample? Does the sample fulfill this criteria? According to the topography of the lesion, keep in mind at this stage that you might have an ectopic tissue, okay? In case the sample isn't adequate, you proceed with the next step, C, but we remember to make a comment about adequacy in step E. Once we have answered these questions, we move on to C, cancer, what we all have been longing for. Morphology, morphology, morphology. We consider morphology, and if needed, we perform any ancillary techniques. At this stage, we decide about the neoplastic or not character of the lesion. Is it normal? Is it neoplastic? Is it benign, suspicious, or malignant? What type? Can we tell if it's a primary lesion or a metastasis? Taking into consideration all the above steps, correct, A, B, C, we finally reach D, which of course is diagnosis. Mahatma Gandhi wasn't a doctor, but he said something extremely wise. A correct diagnosis is 3/4 the remedy. And because diagnosis is always so easy, sometimes we have to recruit differential diagnosis. At this stage, do you make a decision in your mind? I do. Now that we are completely done with D, boom, it's the time to E, exhibit our findings by writing a report. Our report wants to be as clear as possible, so it can provide sufficient guidance to clinicians in planning further management of the case. And that was it. Available information: B, body; C, cancer; D, diagnosis; E, exhibit. ABCD. But how did we come up with this idea? Like Massimo, he gave you the answer at the introduction. Thank you, Massimo. It was during a first aid training where we use the airway, breathing, circulation, disability exposure algorithm in order to treat what kills the patient first. I tried to combine emergency medicine and cytology, and I ended up with what kills your diagnosis first. My diagnosis, your diagnosis, what kills it first? If you make a diagnosis for a wrong person, this can kill your diagnosis. Maybe you have made the most elaborated report you have ever written, but you have already killed your diagnosis. If you don't know that the patient has, for example, let's say a melanoma, the great mimic, this can kill your diagnosis. And if you make a diagnosis without having an adequate sample, this can kill your diagnosis. You get the pattern. The idea was born around 2014, and after several rejection letters, has anyone tried to publish in Nature journal? I failed, and I felt like a failure. You think you have this super idea and you're excited and passionate and you write and you send your submission, and then boom, you're not enough. Rejection letter, rejection letter, rejection, 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 until the idea was received with a welcoming letter of approval from Dr. Klaus Kaiser. He was published in Diagnostic Pathology Journal as Cytology ABCDE. And then we announced it in the European Congress of Cytology in Milano. Then we realized that this ABCD is generic and can be used whenever we have a medical image to evaluate, interpret, right, Lucas? So we took part in the 3rd International Medical Olympiad contest, and it was published in the Proceedings as Diagnostic Medicine ABCDE algorithm. Since my sister-in-law is a magnificent European patent attorney, we tried to patent it, but it just wasn't possible. We presented the impact of the ABCD in our everyday practice in the European Congress of Cytology in Malmo. You were there, Massimo, I remember you in the audience, and Tuguba, who was in the morning. Are you here with us again, Tuba? And just when the pandemic was about to start to spread, the ABCD was my ticket in order to receive a part scholarship for the TED Med in Boston. Boston, beautiful. Do we have people from Boston in our audience? Right, a yes in the chat. I can see. A few months ago, I won the local science communication contest by presenting the algorithm from the patient's point of view, like a reversible garment that you can wear it inside and out. We presented it from the patient's point of view, how patients can use it. Does any of you know the FAME-Lab contest that it's taking place in Cheltenham? No one? FAME-Lab contest? Okay, it's an international contest of science communication contest. And you have 3 minutes. You have to win the crowds. Here is how I presented the algorithm, but from the patient's point of view. Okay, here you are.
Ας τα απολαύσουμε. Αγαπητοί FAME-Labers, σήμερα θα σας δώσω ένα πολύτιμο εργαλείο για το πώς να διαβάζετε μια ιατρική εικόνα με το πόρισμα που τη συνοδεύει. Λέγεται συσχέτιση ABCD και είναι ένα σύνολο βημάτων που έχουμε αναπτύξει στο εργαστήριό μας, στο νοσοκομείο Παπα-Νικολάου. Φανταστείτε ότι είστε στα εξωτερικά ιατρεία ενός νοσοκομείου, λόγω ενός επίμονου βήχα που σας ταλαιπωρεί εδώ και πολύ καιρό. Μόλις κάνατε μια ακτινογραφία θώρακος. Σε λίγο βγαίνει ο γιατρός με την αστραφτερία σκρυποπιά και σας δίνει την ακτινογραφία με την ιδιάζουσα μυρωδιά στο χέρι. Αρχίζετε να ανησυχείτε γιατί αισθάνεστε ότι κρατάτε στα χέρια σας τη στήλη της ροζέτας και μάλιστα από τη μεριά των ιερογλυφικών. Και δεν υπονοώ τίποτα για το γραφικό χαρακτήρα των γιατρών. Εκεί που αγχώνεστε, ξαφνικά θυμόσαστε μία FAME-Laber που έλεγε κάτι για ένα ABCD και ξεκινάτε. Βήμα-βήμα, step by step. Oh baby. Βήμα πρώτο, συσχέτιση. Συσχετίζετε το όνομα στην ακτινογραφία με το όνομα στο πόρισμα. Αυτονόητο. Θα σας θυμίσω περιπτώσεις ασθενών που ήρθαν με σπασμένο χέρι και τους είπανε ότι είναι έγκυοι. Με μελέτη μας αποδείξαμε ότι το βήμα συσχέτιση προστατεύει από το ιατρικό λάθος και από τα έξοδα των δικηγόρων. Βήμα A. Available information. Κλινικό ιστορικό. Τι σας οδήγησε στο γιατρό? Ο βήχας. Του αναφέρατε το πλήρες ιατρικό ιστορικό. Ένα καλό ιστορικό αποτελεί τη βάση μιας σωστής διάγνωσης, Ιπποκράτης. Βήμα B. Body. Σκέφτεστε. Ποιο μέρος του σώματος εξετάζεται? Ο θώρακας. Κοιτάζετε. Είναι επαρκής η εικόνα? Ναι, βλέπετε όλο το θώρακα. Βήμα C. Cancer. Δεν τρομάζετε από τη λέξη, γιατί γνωρίζετε πολύ καλά ότι στο βήμα αυτό οι γιατροί εξετάζουν την εικόνα και κρίνουν αν τα ευρήματα είναι φυσιολογικά ή όχι. Παρένθεση, να σας πω ένα μυστικό. Οι εργαστηριακοί γιατροί λατρεύουμε να έρχεστε να μας χτυπάτε την πόρτα και για να σας εξηγήσουμε τους εύπλαστους εφάνταστους επιστημονικούς όρους που χρησιμοποιήσαμε προκειμένου να περιγράψουμε στο βήμα C τη συναρπαστική ιστορία της ασθενειάς σας. Κλείνει παρένθεση. Και τέλος, βήμα D. Diagnosis, όπου διαβάζετε στο πόρισμα την τελική διάγνωση, την οποία οι γιατροί ετοιμάσαμε με λεπτομέρεια και αγάπη για εσάς. Συσχέτιση ABCD. Ένα δοκιμασμένο, δομημένο και δωρεάν εργαλείο. Την επόμενη φορά που θα πέσει στα χέρια σας ένα πόρισμα και μία ιατρική εικόνα, πάρτε τη διάγνωση στα χέρια σας, εφαρμόζοντας τα βήματα συσχέτιση ABCD. Ευχαριστώ.
And that was the ABCD from the patient's point of view. They can use it as well. You see, it's a reversible garment. These steps are followed as an ad hoc procedure by most of us. But when we are facing a difficult case in our laboratory, a real difficult one, we always run correct ABCD in our mind. It helps us stay confident and always on the right track. We also use it when we want to present a case, because it's a well-structured and systematic way of thinking that provides consistent set of steps and rules for a reliable diagnosis and for presenting a case. We use it when we want to write a case report. We use it to communicate our findings and our observations in a more coded way. I always wonder, am I the only one so passionate about this algorithm? And then really awesome people, some of whom are in this Zoom meeting today, find this algorithm a great and brilliant idea, and they even express their support through social media. And prominent colleagues like Fernando Schmidt, Dr. Philip Viel, Dr. Edmund Sibas, Dr. Eric Lassi, Dr. Roberto Samura, Dr. Lola Lozano, and young leaders like Eduardo, Tanya, Lara, Sara are amazing supporters of the idea. What is my vision for this algorithm? My vision of the future of the ABCDE algorithm is that it will become widely spread and used, and we should start by educating students and young colleagues. It's a practical and educational tool that adds an element of fun and guidance to the learning process. It's generic and can be used as a common language among doctors of different specialties. Once it's part of their education, I believe we won't be struggling to get clinical history anymore. This is a miracle. Students will be able to understand and appreciate better pathologist and radiologist role. Now, it's time to get your opinion on this ABCD. I would like to hear your comments, your questions. We are not going to have a question and answer session later, so now you can make your questions and your ideas on how we can make it better, how we can improve it, what needs to be added, what needs to be removed, to be changed. Now it's the time to make it our algorithm. So the idea is not mine anymore, but ours, our big cytology family. Let's see how we can make it our algorithm. We can work on this together. Thanks, Philip. So do you have any questions? Do you have any comments? So you can write it down or you can speak. Or if someone said that the word cancer should be changed. Yes, it's scary, I know. If you have another proposal, you can email me. This is my mail. You can always use it. And you can mail me your ideas and we can make a new publication, elaborate and to make a better diagnostic medicine ABCDE. We should improve, always improving, always improving. Like this presentation is better than the presentation in the morning, always improving. Okay, any questions before we proceed?
Christina, there are some comments on the chat.
I don't see the comments. Okay.
From Lucas?
Yes, from Lucas Daldiel. Is it the same structure I use and teach to residents? Ah, okay. Thank you, Lucas. Yeah, but this is a constructed structure, right? You can use like ABCD. You will say to your residents ABCD, and then we can communicate with this coded way. Yes, exactly. Great. 2 thumbs up. Thanks, Dr. Ali. Thank you, Manos. The medicine is not torn apart in specialties. Improving common language between medical specialties must be a target. Yes, exactly. Esperanza, very good to apply to review. And yes, Esperanza, exactly. Okay, I proceed now. And here is the Alexa of our medical diagnosis. To round it up, the diagnostic medicine ABCDE algorithm could be the Alexa of our medical diagnosis or any other automation system like this. Do you know Alexa Amazon? It's an helper device, intelligent helper device. Alexa?
How can Alexa help you today?
I want to diagnose this slide, please.
Is it correct? Do you have all available information? What part of the body is under your microscope? Do you have an adequate sample? Is it normal? Is it neoplastic? Is it malignant? Do you already have a differential diagnosis, or do you need to perform more auxiliary techniques? Please consider all the above to reach your diagnosis. Now, write down your report.
Thank you. And remember, the Alexa of our medical diagnosis is both a Ferrari and a Volvo that drives us fast and safely towards the correct diagnosis. Dear colleagues, you can find this diagram on the Twitter, Facebook, and LinkedIn, or you can email me your address, and I can send you a laminated diagram like this one. Share it and use it. It's our algorithm. Dear colleagues, Diagnostic Medicine ABCD algorithm is in your hands now.
Thank you very much, Christina. How can we do do not forget to check the A of your algorithm? I mean, how can we do not forget to control the demographic and also to control the correspondence in between the slides we have on our microscope and the slide that were prepared? Because this is something that we usually forget to do that.
How can we not forget the letter A?
Because sometimes we just go to the diagnosis and we forget to check the lines and so on.
Yes, yes, of course. But if we have this like ABCD, when you have a slide and you get it, and then you say, is it correct? A, available information. So what do I know? Especially when we are in this process of making diagnosis every day, we might forget. And then in the morning, some people said that I do the A after the C. I do the morphology and then I check the history, and if it complies, it's okay. But when we have, when you have a difficult case and you are stuck, you can run this ABCD, and this can make you feel more confident. And then there you not forget, because you say, I will run now the ABCD. So what's A? It's available information. That's the way. You have this laminated. I will send it to you, to everyone who wants. I can send it so you have it on your desk, and then you don't forget.
I have a question.
Yes, please.
Yeah. Well, sometimes I have a problem with the A. Because, yes, of course, probably the majority of us has a problem, have problems with A, because the clinical history is sometimes difficult. We have difficulties in getting the clinical history. And particularly when we are referring to the ABCD, C cancer has the most important impact in our diagnosis and in our flow chart. And how you have taught the particularly oncologist to give you the clinical history, the correct clinical history? Sometimes they have a lot of problems in giving the clinical history because the patient has a long and interrupted the clinical history. And sometimes we need these clinical histories to make a diagnosis. How do they comply with your algorithm?
Oh, thank you, Dr. Fada. Hello, Italy. That's why I said we should educate young colleagues and students. So once it's part of their education, they are going to know that we need it because it's the basis for our diagnosis. It's so super important. That's why it's very important to educate the young colleagues with this algorithm, so they know that it's a basis for any diagnosis and for their diagnosis as well. As for our oncologists, we try to have a very good communication and collaboration. We still have a long way to go. That's it.
Someone suggests you, Guido, to use your cell phone. It's trivial. Probably to call the clinician.
This is probably is the top of the list are the numbers of the oncologist, the
Yes.
number of the clinician, and I pay a lot of money by calling them, but I have a lot of, and I disturb them many times.
We have Lucas that have raised his hand. So Lucas.
Yes, please.
Okay, thank you, Christina. It's a structured, simple, but very well-structured method to reach the target of our work, good clinical practice. I'm a radiologist, and I think the worst part of the algorithm is A. As I wrote in advance, colleagues does not provide us with a clinical scenario. In radiology, as you know, it has been much more complicated from the era of the simple X-ray of the thorax, okay? So we are reaching the era of artificial intelligence, radiomics. Despite all that progress, we need clinical impaction. Most of our colleagues forget that we are not just technicians, we are doctors as they are, and most of the time are seeking our big advice.
Thank you, Lucas. Well, Lucas is a radiologist. We work at the same hospital, and we have the same problems. And yes, it's I guess it's an international shortage of clinical history to people.
That I was hoping to hear from my colleagues during the presentation. Is the same situation in all parts of the world?
Yes, I can reassure you. We'll talk in the hospital tomorrow.
So it's a target for us.
Thank you, Lucas.
So thank you, everyone. I suggest you, Christina, to write again your mail in the chat because it went up.
Before
yeah.
I didn't send the link to the
video.
Yeah, just give me 10 seconds. And
in the meantime, I would like to remember everyone that the next webinar will be on March, the Friday, 25, and it will be done by Marta Pittman about the WHO International Reporting System for pancreatobiliary cytology. Wow. And we will have only one presentation.
So here is a link. Here's a link to the video. If you like it and if you wanna give a thumbs up, please go ahead, feel free. I'm not going to stop you. Okay, and
so just to remember, sorry,
if
Christina.
the slides stay for a long, okay, all the other questions I will say in the chat and I will reply to you so we can end our session here and be on time. Thank you.
Christina,
everybody,
just to remember,
for being with us today from all over the world. Have a nice day. Have a nice rest of your day, even if it's a morning, afternoon, evening, night, whatever. Thank you.
Thank you. And just to remember that the next webinar will be at 1 p.m. Zurich time or 8 a.m. at Boston time on March the 25. Thank you very much to everyone and see you next time.